This is our evidence-based practice review. See here. So focus of this study is teaching for cardiac patients at home to reduce medication errors. We recognize that for cardiac patients that there are quite a few readmissions that happen as a direct result of medication errors back at home. Now, these readmissions, they can either be because of mistakes that are made by caregivers, by the patients. Maybe the patients have overdosed themselves, underdosed themselves, or they are just not taking the medications correctly because they don't know. The most common admitting diagnosis for these patients are directly related to the administration of Coumadin, digoxin, toxicity, syncope episodes, hypertension, heart failure complications. They might have severe bradycardic episodes related to taking medications incorrectly. Now, in the healthcare field, hospitals, nursing staff in particular, we play a huge role in providing continuous education throughout the entire hospitalization as well as upon discharge. Now, we understand that there's a lot of different factors that can go and interfere with the patient's understanding of their discharge instructions, possibly their age, their memory, their vision, their hearing problems, cultural beliefs. And so for this reason, we need to go and thoroughly assess where they're at, and we also need to go and appropriately intervene. Continuous instruction for these medications, it shouldn't stop once the patient goes home. This should be continued at home. They should continue to be getting education about their medications, and they should be getting assessed on the compliance of how they're doing their medication administration once they're at home. And we suggest that we do this in order to decrease medication errors and potential harmful effects it can have for these patients. For our clinical question, our PICO question is, among cardiac patients, do follow-up patient teachings in their homes reduce medication errors versus patient teaching at discharge alone? And the purpose of this study is to assess if home medication education would decrease the number of medication errors for this patient population. When we're looking at the stakeholders and the impacts, we have the patient. We're looking at reducing medication errors as well as death. The nurse, providing continuous education upon discharge throughout the hospitalization and once the patient is at home. The hospital, looking to reduce readmissions for the patients with chronic conditions. And the stakeholders in this is nursing administration, nursing staff, case managers, physicians, and the patient caregivers. Impacts, reducing hospital costs, readmissions, prevent harm to the patients, sometimes death to the patients, to increase patients' medication regimen compliance. So the clinical question is, once again, among cardiac patients, do follow-up patient teaching in their homes reduce medication errors versus patient teaching at discharge alone? Now, in order for us to better understand how we can prevent medication errors, our group, we decided to go in and use the evidence-based practice approach to find the best research and the best practices that can prevent medication errors among these patients once they're at home. So in regards to the systemic search for research and evidence, we used our book on page 49 through 73 in chapter 3, the gathering and appraising the literature from Lobiondo and Wood. So we use their steps and their guidelines. We use multiple different search engines to go into search and find for these literature. We used keywords such as medication errors, home education, and cardiac patients in these searches. And literature has been searched widely, and multiple resources have been gathered to answer our question by using evidence-based practice approach. Now, all evidence that we were able to go and get our hands on was retrieved using quantitative studies, meta-analysis, and evidence-based practice guidelines. In nurse-led heart failure clinics, improve survival and self-care behavior in patients with heart failure study. 106 patients were randomly selected and assessed and assigned to either follow up at a nurse-led heart failure clinic or to usual care. The purpose of this trial was to evaluate the effect of follow-up at a nurse-led heart failure clinic on mortality, morbidity, and self-care behavior for patients that were hospitalized due to heart failure for 12 months after discharge. As a result of this one, after the 12 months, the follow-up interventions were associated with a 55% decrease in admission and fewer days stay at the hospital. There were more patients' deaths reported in the control group than in the patients group who received or consumed follow-up care. Several other studies have been selected from our group members that also confirmed the significance of follow-up visits at home education of medication regimen in these cardiac patients. In order to go and grade the evidence on page 15 of the Biondo and Wood and Haber book, we used the information provided on that page, the hierarchical scale. Now, this scale, it studies, it'll give you the strength of the design and the meaning, the fullness of the evidence. And this scale, it will rate the evidence from a 1 to a 7. Now, 1 is the highest level of evidence and 7 is the lowest level of evidence. So for level 1, it's a systemic review or meta-analysis of randomized control trials, evidence-based practice guidelines based on systematic reviews. For level 2, it's a well-designed randomized control trials. Level 3, controlled trials without randomization, so that's more like quasi-experimental. Level 4 is a single non-experimental study, case control, correlation, cohort studies. Level 5 is a systemic reviews of descriptive and qualitative studies. Level 6, a single descriptive qualitative study. And level 7, it's the opinion of authorities and or reports of expert committees. So the research for this study, it kind of ranged from a 2 to a 6. We didn't have any level 1s because this is more of a newer issue that's being researched. So the information just wasn't necessarily there for a level 1 study. So the quality of evidence, we assess the quality using the grade working group criteria described once again in our book on page 425. That's the Biondo and Wood and Haber book. The evidence quality ranges from very high to very low, and high quality research, it indicates that further research is very unlikely to change the findings of it. Now, like I said before, because this is a pretty new topic, no evidence was graded as high. Now, moderate evidence indicates that further research will have an important impact on the confidence in the estimate of the effect and may change the estimate. So quite a few of ours were moderate. And then low evidence means that further evidence is very likely to have an important impact on the confidence and the estimate of effect and is likely to change the estimate. So very low means that the estimate of the effect is very uncertain. Now, although we do have randomized control trials from the research that we did, none are exactly specific to our topic. So given that the evidence was graded to low to moderate. Now, so the strength of it was evaluated using the quality, quantity, consistency, and relevance that was once again described in our book, the Biondo, Wood, and Haber on page 427. So quality is going to go and indicate that the aggregate of quality ratings for individual studies predicted on the extent to which bias was minimized. Quantity relates to the magnitude of the effect, number of studies, and the sample size or power. Consistency indicates that for any given topic, the extent to which similar findings are reported using similar or different study findings. And the relevance of the finding characteristics to individual groups. Now, all studies minimized the bias and were, we thought, of good quality. The number of studies conducted on the topic are, once again, pretty low. The studies consistently reported the benefits of medication education and its role in preventing harm to patients and preventing medication errors. This was well known. Now, the way that we were able to go and critique the current evidence-based practice guidelines. So these guidelines, they need to be evaluated and to understand methods for creation of the guidelines and how well the guidelines could be used in practice. In our textbook, the Lobindo and Woods and Habers, it's suggested by looking at a few different things. We want to look at when this publication was dated. You know, if this thing was written 100 years ago, it might not be as relevant as something that was written earlier this year. Who exactly endorsed these guidelines? The purpose of the guidelines, the specific population that they used, the types of research that they used, the descriptions of how they graded the evidence used for the guidelines, information on how they searched for the information, references of the articles used for the guidelines, what experts have reviewed the guidelines, how well the guidelines have worked in practice, and for what population and what settings. Agreed to appraisal of guidelines, research and evaluation. Two was used to evaluate the evidence-based practice guidelines, which looks at 6 key areas. So the scope and the purpose of the guidelines is examined. The stakeholder involvement is examined. The rigor of the guideline development, the clarity and presentation of the guideline, the how applicable the guideline is to practice, and that demonstrated editorial independence of the developers. So in regards to the synthesis of the research, we have a few different articles that we were looking at. This first one by Meredith Feldman Frey, this one looked at improving medication use in newly admitted home healthcare patients. And their research question was, does adding a structured collaboration between agencies, visiting nurses, and specially trained pharmacists, does that improve medication use in newly admitted home health patients who are identified to have potential medication problems? So this was a randomized control trial. And the results of this study, it led to an overall, the interventions that they did led to an overall improvement in medication use with an attributable improvement of 12 patients out of 100. Some of the strengths we recognize is that strength is that wide application with minimal use of outside resources. But one of the weaknesses is that it did not include economic analysis due to limited sample size. So we said that this was a level 2 and that the overall quality was good. So a summary, in summary, there is an increasing need for an effective medication improvement program as vulnerable patients become more dependent in home health service. Another article that we looked at was the idea of looking at teach-back and using teach-back. This is from Kornberger, Gibson, Sadowski, Maleta, and Klingbeil. And this study in particular looked at using teach-back to promote a safe transition from hospital to home. The idea of teach-back is throughout the patient's hospitalization. We are giving them these medications every day, sometimes multiple times a day, and having the patients go and teach back the information about it. So as a nurse, we want to teach them, okay, this is what the use is, these are the side effects, this is how you go and administer it. And in order to have, in order to know that they understand it, we have them teach back the information to us. Every time the patient is given a medication, they should teach back the information to us. So this is a review and a descriptive study. The results of this test was that 92.5% of the nurses that were involved, after they sat down and did a test or did a class and did a briefing on it, they confirmed they knew what health literacy was. Now, only a very small amount of these nurses, after they were in this study, said that they didn't really use teachback anymore. And most of the nurses in the study found that teachback was very beneficial. A strength of this test was it confirmed the ability of nurses to recall, utilize, and appreciate teachback. One of the weaknesses was that the sample size was small, the lack of assessment of the increase or decrease in readmissions or discharge complications for the patients directly related to teachback. We said this was a level 5. It was a good study. Yeah. Another one was from Brunning and Selder. This article from Hospital Home Health Care, the need for medication reconciliation, home health care nurse. So the question here is, do the discharge medications from inpatient facility, does it match the home health care admission medications directly after discharge from hospital? So this is an exploratory study. And the results of this test was that only 40% of the patients' discharge medication numbers actually matched the home health medication list, which means that 60% of patients had a different number of home medications when compared to discharge medications list. The median number of medications was 9 for discharge and 9.5 for home health list. So this is a discrepancy, and it was defined as an inconsistency between the two sources of information: the inpatient discharge, home health care admission, or ongoing home health medication list. So it found that basically there's this gap between when a patient's discharged and when they're admitted to home health. So the strength is that it describes the potential for medication errors for clients when they're discharged from the hospital, and the benefit of having medication reconciliation done, and potential to prevent medication errors. Now, the weakness, however, of the study includes that the sample size is pretty small, and the sample came from one hospital and one home health care provider, so the information might not be as applicable to everyone. We said that this is a level 6, and the quality is good. So recommendations. After going and reviewing all these different articles and studies, we were able to go and come up with multiple recommendations. So readmissions, noncompliance, and improper medication administration once discharged, these are all directly related to low health literacy. So in order to address this issue, medical staff in the hospital, they need to, one, use language that the patient can understand, using smaller words that anybody can understand. Limit the amount of information taught to 3 to 5 new subjects at a time. Some of our patients, especially ones that are cognitively impaired, or maybe they don't have the best memory, we don't want to overwhelm them. Teach the patient, assess understanding, and reteach information to the patients throughout the hospitalization. Utilize teachback to determine if the patient understands, or have the patient demonstrate proper technique back to you. Once again, with that one study, 98% of nurses who participated in the teachback study found that it was beneficial, and 45.1% of those participants continued to use it after the research study had been concluded. Patients with heart failure are at risk for readmission, poor health outcomes, as well as death once discharged from the hospital. Creating a nurse-led heart failure clinic can reduce these risks, as well as these poor outcomes for patients with heart failure. Now, if they do go and create a nurse-led heart failure clinic, they should incorporate specialized nursing staff with training and experience with heart failure patients. Give the staff the ability to make protocol adjustments to medications. Provide patients with social support, as well as education regarding their condition, treatment, and medication. Have patients follow up within 3 weeks of when they're discharged from the hospital. Now we understand and recognize that adverse reactions and poor medication compliance, they're on the rise as hospitalizations the lengths of stay are becoming shorter, and healthcare is moving more into a home environment. So multiple interventions need to take place in order to reduce these issues in the home health setting. Medication should be constantly reevaluated for mechanisms of actions, for those being duplicated, or for unnecessary prescriptions. Patients taking any psychotropic drugs should be screened for adrenergic effects, and appropriate changes should be made to their medications. Cardiovascular medications should be prescribed with prudence, and patients should be taught the potential side effects of these medications and should demonstrate proper medication compliance when taking them. Non-steroidal anti-inflammatory drugs should not be prescribed to patients who are at risk for developing peptic ulcers. Cardiac patients are among the patient populations that would need complex care after discharge. And so it's therefore necessary to provide continued care after discharge to ensure that the patient or the caregiver would understand the plan of discharge, including the medication regimen. Referring the patient to home health and collaborating between the pharmacist and visiting nurse, the physical therapist, occupational therapist, the physician can all benefit any patient with a complex disease process, including these cardiac patients. So the best practice intervention package is a medication management supported by a home health quality improvement organization support center. That's a mouthful. So in this, we want to do a comprehensive assessment to identify if they have any issues with medication management. We want to go and make sure that a medication reconciliation is done as required by JCAHO. Address the different multiple players and multiple issues. Collaborate and easy communication among the players. So address patient caregiver issues. So maybe there's a lack of a caregiver and they need help. Maybe they have literacy issues. They don't know much about the medication. There's cognitive deficits, functional limitations as well. Additionally, we need to go and assess for cultural beliefs, fear of addiction, non-adherence to their medication plan, lack of safe system setup, financial problems, polypharmacy, and medication abuse. We want to go and address the healthcare provider issues. So completion of a comprehensive medication management assessment, use medication non-adherence staff education tool, effective pain management, the lack of universal management tool between settings, so between hospitals, home health, nursing homes, physicians' offices. Complex medication regimens, we want to use a simplified protocol. We want to identify and stop any inappropriate medications that were prescribed for elderly patients. So we use the Beers criteria for that. And non-utilization of appropriate compliance aids. Another recommendation is the absence of making appropriate referrals with medication issues, including nursing referrals to any identified medication knowledge deficits and issues, physical therapy for strengthening and gait training for reach medications, occupational therapy for appropriate compliance aids, and incorporating medication administration to establish daily routines, like being able to go and open up their medication packages. For swallowing issues or cognitive issues, multi-step medication administration, and medical, social worker, or financial issues that may affect medication regimen. Suspected medication abuse, psychological problems such as depression, or issues related to general reluctance to take medication. Outcome-based quality improvement measure of management of medications. Now, this is derived from OASIS data that measures the change in the patient's health status between 2 or more time periods. And this includes a 37 risk-adjusted outcomes measure. Step 1 is a focus group, how we would go and implement this into practice. So present this evidence-based practice results to a focus group. Ask participants how this will improve the adherence to medication. Ask participants how interventions will impact the patients and hospital staff. Ask participants how similar interventions have been successfully adopted. Step 2 is to engage. So participate in healthcare conferences by submitting a poster presentation of evidence-based practice results. Reach out to the social network of change leaders in the area of cardiac surgery. Simultaneously engage change agents with evidence-based practice results and seek input on further refinement of patients' education methods and medication adherence. Once again, the OASIS one. And let's see, the absence of making appropriate referrals with medication issues, including nursing referral for any identified medication knowledge deficits and issues, physical therapy for strengthening of gait. I think we just read this. I'm sorry about that. I'm not sure exactly what happened. We did this. Did this. Over here. Okay, so step 3 is to educate and train. Administer brief medication questionnaire. Provide patient education on medication adherence based on results. 3 weeks post-op to reassess patient utilizing the BMQ, and provide additional medication education for patients failing to adhere to the required medications. Step 4 is to analyze and adjust. So we want to track the implementation of the evidence-based practice, seek out success stories, put them into action, and consult with individuals that have implemented this plan and make necessary adjustments. This is a brief questionnaire that we can have our participants go and take. Evaluation plan would be to assess the effectiveness, create a timeline for interventions, pre-test and post-test using questionnaires, gather patient response on instructions or teach-back method, analyze the data with original focus groups, and make necessary recommendations. And these are our references.